Terrific. Thank you, Jason, and thank you, you guys, for having me. I'm really happy to come and chat with you guys about my residency project from last year. So, for those of you I haven't met, my name's Brandon Kennedy. I'm one of the staff pharmacists now here at the Regina General Hospital, and last year I was one of the pharmacy residents. And in that year, I was able to conduct my residency project, my residency research project on an assessment of opioid prescribing post-appendectomy or hernia repair. I was lucky enough to work with Jackie Myers, who's one of the members of your stewardship team, as well as a few other folks that I'll mention nearer to the end of the presentation. But for now, I'll just jump right into it. Okay, so just to briefly outline how this presentation is going to go, I'm basically going to go forward to back through the process of my project's inception, a little bit of the background ideas, and then dive into the results, kind of the inferences that we made and limitations, and kind of where we can go from there. So to open it up with a little bit of background, so kind of what precipitated this project. So opioid prescriptions have been estimated to be given to up to 70% of patients that are opioid naive post-operative after general surgeries in Canada and the United States. So of these, up to 5 to 10% develop a long-term opioid use. And in most of the literature that I looked at, that was defined as 90 to 120 days post-operatively, they are still receiving at least opioid prescriptions. A few correlative factors that I identified: if patients are getting opioids within 7 days of the day of surgery, and also if they were getting opioids as inpatients in the hospital in general, that makes them a little bit more likely even to develop long-term opioid use. So why does that matter? Why does long-term opioid use in itself matter? Because 3 to 5% of patients have been estimated to develop opioid use disorder when they take opioids for over 7 days. Opioid use disorder being defined as problematic patterns of opioid use leading to a clinically significant degree of impairment. And not only does this have health systems impacts and sort of economical impacts, up to $504 billion in the United States in 2017, but it also, I think maybe more importantly, but it impacts our patients as well. Significant morbidities and mortalities, and as well as the increased risk for opioid use disorder in itself. So in the field of general surgery from 2002 to 2016, it was found that the use of opioids, the ordering and the prescription of opioids, increased significantly. Yet, when you dive into patient-specific opioid use, the use of opioids post-surgically appears low. And I'll use one kind of study that illustrates this, I think, to a good degree. This study looked at post-operative patients in the United States, and they found that 36% of them had received no opioids in the 24 hours prior to discharge. And despite that, nearly half of them, amounting to 3,000 patients in this sample size, they still ended up receiving an opioid prescription on discharge. So that basically illustrating a little bit of a discordance between opioids that are being given and opioids that are actually needed. And when that happens, that can lead to increased rates of opioids in doses and in volumes of pills being present in the community. And there have been a few studies in the United States and Canada that illustrate this fact, showing that 55% of folks using opioids non-medically, they obtained it from friends or family, as opposed to from physicians or from illegal drug dealers. So this is kind of a notable finding. So now that we've identified kind of the topic, the issue, what has been done to attempt to mitigate or reduce opioid prescribing? And this is by no means an exhaustive list. The list gets bigger every day. This is such a pioneering field right now, so new stuff comes out every day. But some examples of things that have been done: there have been statewide guidelines initiated to try and give guidance on pill quantities to be given after certain surgeries, etc. There have been educational interventions, and these could be on the side of the prescribers or educational initiatives to patients, and both of those have been used. As well as something I found that was interesting is that the presence of a pharmacist on the care team has also been found to reduce the amounts in terms of doses and in terms of pill volumes of opioids given to patients. In terms of commonalities and initiatives that have been successful or have been trialed at least, is that the most successful ones have been locally developed. At the realm of provincial or statewide guidance sometimes, but a lot of them are very site specific or hospital specific, and all of them are multidisciplinary in nature too. When you're creating initiatives such as these, you want them to be multidisciplinary so that all stakeholders are involved. So once you know that a problem exists and that some things have been done to attempt to alleviate a problem, the next question becomes, if we're trying to foster opioid stewardship in our site, how do we measure it? And that's kind of where this next slide comes in. In 2019, the American Society of Health Systems Pharmacists, they came out with a set of quality indicators for measuring opioid stewardship. So basically, all that was a list of kind of tangible things that allow you to measure opioid stewardship. And their main points of emphasis are on encouraging safe opioid use in hospital and on discharge, as well as considering the feasibility of implementation. You can make a list of things that could perhaps allow you to measure opioid stewardship, but it won't matter much if you can't measure it. So that leads us to the study that I conducted during my residency. So our study sought to assess postoperative prescribing patterns in the SHA Regina area in patients undergoing appendectomies or hernia repairs. We selected these two surgery types based on sort of the prevalence of common general surgeries, as well as sort of the patient population that we were looking for. We thought that these two surgeries would fit well. Our main objectives to meet that purpose were to determine inpatient opioid prescribing patterns in the SHA Regina, as well as discharge prescription patterns. We wanted to characterize the use of medications that are known to increase harm when used concurrently with opioids. And finally, we wanted to assess the rate of utilization of inpatient non-opioid analgesia with acetaminophen and NSAIDs in our area. We were looking at patients that were over 18 after one of those aforementioned surgeries that were in hospital for greater than 24 hours at either the RGH or Pascal Hospital. We excluded those who were discharged in a complicated fashion, those who were pregnant, had active malignancy, opioid use within 90 days of admission, or identified opioid use disorder. We were looking to analyze previously opioid naive patients. And our methodology was we were conducting a retrospective chart review. Our target was 100 charts or full years of eligibility charts, whichever came first. And this is a list of the quality indicators that we selected from that previously mentioned ASHP document. There were 18 quality indicators total, but we selected these 9 on the basis of kind of feasibility of collecting data in a chart review. Some of them were more qualitative types of opioid stewardship quality indicators that wouldn't be as easy to measure, and these ones just seemed to be kind of high yield data points. So we looked at multiple PRN opioid orders, the presence of long-acting or extended release, the average dose expressed in morphine milligram equivalents or MMEs per day, some information on discharge prescriptions, the presence or absence of one of these medications known to increase risk for harms, so benzos, barbiturates, sedative hypnotics, namely zopiclone, GABA analogs, and muscle relaxants. And then just looking at the actual and potential usage of doses greater than or equal to 50 or 90 morphine milligram equivalents per day. And those are the frames of reference that are used in pain control recommendations in terms of opioid use, those 50 and 90 cutoffs. So that's why those are there. Just a little bit of more detail about our methodology. The collection of data on the use of NSAIDs and acetaminophen was a non-quality indicator data point that we wanted to collect. We just thought it would be important to, and perhaps useful to know just how much we were using these non-opioid modalities of pain control. And in terms of how morphine milligram equivalents were calculated, that's actually kind of an interesting point. We used a Centers for Disease Control resource for chronic non-cancer pain in terms of calculating these MMEs. And there are existing Canadian resources that differ from the CDC resource. We ended up using the CDC resource because there's a bit of a variability in types of resources and types of conversion factors available. And we just wanted to be as close to those used by the background literature as possible. So we ended up using the CDC resource because a lot of American studies did, and the ASHP quality indicators did as well. To hash out exactly what actual versus potential use means, I had mentioned in the previous slide. So basically, we wanted to see the actual number of doses and amounts of doses received by the patient, but we also wanted to see the potential number of doses that could have been delivered per written PRN or as needed orders. So for example, a morphine every 2 hours as needed order. In actuality, they might have only received 1 or 2 doses per day, but potentially every 2 hours they could have received 12 doses. So that would be the distinction. Jumping into my results now. So essentially, we had a sample of 408 patients that were initially brought to us in an electronic list by Health Information Management Service, or HIMSS. And we managed to screen that down electronically to 235 patients before we did physical chart pulls. We pulled 115 physical charts in reverse chronological order as specified, and we ended up finding 100 charts that met our inclusion criteria. In terms of our baseline characteristics of those patients, we had an average age of 50-51, with just over half of them being male, and a median duration of hospitalization of 50 hours. 36% of our patients were hernia repair patients. Of those, most of them were open hernia repairs. And then conversely, 64% were appendectomies. The majority of those were laparoscopic appendectomies. 15% of this patient population was on NSAIDs prior to admission, and then 9% on acetaminophen, and then 10% were on one of those previously mentioned medications known to increase risk for harm. I do want to point out that this is information obtained from physical charts from prior to admission med lists. So the presence of NSAIDs or acetaminophen may have been underestimated here because these are over-the-counter medications. They might not have shown up on a prescription list because folks could have just gone and bought Tylenol over the counter, for example. Jumping into my inpatient data, so I know that it's probably piking some of your eyes that our total population here is 73, and I will talk about that later, but our total inpatient analysis is using an N of 73. So we found that 97% of this inpatient group had a opioid prescription ordered. Of those, 81% had multiple PRN opioid orders, and none of them were long-acting or extended release opioids. So we're looking at around 2 opioid orders per patient on average. Just over half of those were hydromorphone, followed by morphine and codeine, and it was an exactly 50-50 split between IV and oral formulations of opioids. Excuse me. So in terms of one of our other quality indicators, the median morphine milligram equivalents per day, we found that our inpatient group received a median of 0.6 morphine milligram equivalents per day, which is relatively low. We had an IQR of 0 to 11.1. And all things considered, we ended up having 35 patients out of 73 that actually received no opioid doses at all during their inpatient stay. Going into our actual versus potential opioid use, we found that 4 out of 73 patients received doses greater than 50 morphine milligram equivalents per day, and 3 of those were greater than 90. You can contrast that with the potential usage based on those as needed, those PRN orders. We find that nearly all of our patients potentially could have exceeded 50 morphine milligram equivalents per day, and only one of them couldn't also exceed 90. Moving on to our discharge prescription data. we found that 62% of our patient population received a discharge opioid prescription. And of those, just under half of them, 47%, were found to exceed 50 morphine milligram equivalents per day. And again, this is an extrapolation based on potential maximum usage as the prescription specifies. Because they were discharged, and this was a retrospective chart review of inpatient charts, we can't see exactly how much opioid they used when they left. That's just a matter of fact. So this is an estimation based on prescriptions written. We found, using that same extrapolation, that only 4 of these prescriptions exceeded 7 days of therapy, which was another one of the quality indicators that we were looking at. So overall, a majority of our patients received an opioid discharge prescription. The majority of these were hydromorphone or Dilaudid, and followed by around 26% codeine or Tylenol number 3 orders. This is a nice kind of quality assurance point that I like to bring up. Of the 100 charts that we looked at, only 1 was missing discharge data, like the sheet that held the discharge prescription information. They had written that a prescription was faxed to a community pharmacy, but they didn't describe the contents of the discharge. So when we were designing this trial, this was one of the potential concerns that we had brought up, that a lot of the charts simply may not have had the discharge information in the physical chart. So it was really reassuring to see that 99% of them actually did. So that ended up not being a problem. Moving on to objective number 3, those meds known to increase risk for harms. We found that 15% of our group ended up having orders for these medications while in hospital. Of those, it was about 27% of the hernia repair group, and then only 9% of the appendectomies. The vast majority of these meds were benzodiazepine receptor agonists, so basically a benzo such as lorazepam, and also those hypnotics such as zopiclone would be what's being talked about here. 2 of these medications were new initiations where a patient was newly started on these meds, and the rest of them were simply continuations. The patients were on them before they came in, and it got continued once they arrived. Finally, our 4th objective on non-opioid analgesia. We found that 74% of our sample of inpatients had an order for acetaminophen with at least 1 dose administered. Conversely, about 1/5 of our patients, 19%, had an order for an NSAID with at least 1 dose administered, and 16% received both. So that's the data, and now it's time to kind of dive into what all those numbers that I just fired at you pretty fast kind of could mean. So in terms of our first objective, the inpatient data, we found that there's a pretty similar rate of opioid prescription to other studies in our site, i.e. the vast majority of patients receiving opioids. Also similar to other studies, we found that actual use of opioids by these patients was pretty low, especially when contrasted with potential use, which was fairly high. And I would say that this is similar to discordances identified in the literature between the prescriptions or orders and actual usage. We also found that the majority of our patients received multiple opioid prescriptions, and of those, about half of them were for the same opioid, but different formulations. So an example of that would be hydromorphone or Dilaudid, orally or IV, like PO/IV. And then that was about half of the orders were written as such. And it's notable that there was a pretty high degree of variance between sites and between prescribers in terms of potential conversion factors between those formulations. It didn't seem like there was any standardized process being followed when these orders were being written. So that's another just identifiable point, that there was a degree of variance when looking at these orders. Moving on to a discussion of objective 2, our discharge use. Once again, our findings were pretty similar to the background literature. We found that majority of our patients received a discharge opioid, even though a lot of patients didn't need any opioids at all when they were in hospital. Roughly half of these patients received prescriptions exceeding that 50 morphine milligram equivalents per day cutoff, although it is notable that very few of them exceeded 7 days of therapy, which is good. And kind of as I said before, it's similar to the background literature suggesting that those discordances I've already talked about. Looking at those medications known to increase risks for harms, we found fairly little difference in pre-hospital versus in-hospital prescriptions of these meds. It looked like the majority of these meds were simply being continued without it really impacting the rate of prescribing of opioids. And I would say that's a notable finding because these medications do carry additive risks. The reason that those meds in particular are included in the ASHP quality indicators is because specifically they carry increased risk for respiratory depression, especially post-operatively. On top of that, we also have the fact that benzodiazepine receptor agonists have an additive risk for chronic postoperative opioid use. So we're seeing that these meds can have an additive risk in the acute phase, especially postoperatively, and also in the long term, they can increase the risk of development of long-term opioid use. So it's a kind of tangible piece of information to know that that maybe patients are still getting both of them in hospital. In terms of our non-opioid analgesia, we found that a majority of our patients received acetaminophen in hospital, although 1/4 did not, versus a minority, about 1/5 of our patients receiving NSAIDs. And again, this was similar to rates identified in the literature, saying that there's perhaps an underutilization of these modalities of pain control. And similar studies also showed that acetaminophen and NSAIDs both have a tangible opioid sparing effect. So they're definitely a useful pain control method and perhaps underutilized in this patient population. So that's a very quick discussion of my data, and now to discuss limitations. So with a less than 1 year residency project, fairly small in size, that does limit our generalizability of this study. And talking a little bit now about that inpatient data set, you might have noticed the 73 patients on the inpatient side versus a total population of 100. And that's because in our methodology, we had included patients that were in hospital for greater than 24 hours. However, we were only looking at opioid use in the period greater than 24 hours after surgery. And with that, we were just acknowledging the fact that perioperative, like the period just around the surgery, perioperative pain control is quite a lot different, and the use of opioids is quite a lot different compared to after that 24-hour period. So you can kind of see that that error there, how patients may have been in hospital for greater than 24 hours, but then they were discharged less than 24 hours after their surgery. So we weren't able to collect inpatient opioid use data at all, just because of that issue. So that's why our inpatient data set ended up being 73 patients instead of 100. Other limitations: we didn't assess discharge non-opioid analgesic data, which would have been a nice point of information to have. And also, we weren't able to involve other healthcare practitioners, other decision makers in this study. Originally, we had actually wanted to include a sort of focus group style, like a discussion component with the prescribing surgeons, the prescribing general surgeons in Regina, to sort of present them with our data and see what kind of conversation we could spark from it and include that in our project. But unfortunately, because of COVID and because of time constraints, we just weren't able to do that. So we had to put that kind of on the back burner. Moving on to opportunities and recommendations. So I think this project illustrates a pretty good opportunity for standardization of opioid utilization in our sites. Namely, Well, some examples of potential avenues is we could establish daily dose caps of opioids that can be given kind of to alleviate those really high potential opioid uses. We could also standardize opioid selection. As I had mentioned before, there was a fair degree of variability. For example, in Pasco Hospital, you were seeing a lot more prescriptions for Tylenol number 3 versus more prescriptions for hydromorphone at the general. And there's just a bit of variability by prescriber or or by site. So those that could perhaps be alleviated with a bit of standardization. We should also hopefully collect some more data to help provide evidence-based opioid pill limits. This is something that a lot of other sites, especially in the United States, have done. They basically collect more data to see exactly what the right amount of opioids is, the right down even to the number of pills that would be appropriate for giving patients after specific surgeries. Also, I would say that we have opportunities for increasing the utilization of non-opioid analgesia. The studies that I looked at found that a great deal of patients receiving these types of surgeries are able to use acetaminophen and NSAIDs. They're not necessarily contraindicated, and they provide opioid-sparing benefits too. So it's definitely a mode of pain control that I think could be optimized here. And finally, I just wanted to include a screenshot. This is from one of the pre-printed orders or PPOs for general surgery post-op day surgeries here in Regina. And you can see in the analgesic section, we have a list of 5 pain control methods. 3 of them are opioids, 2 are not. They're all grouped together. Doses aren't necessarily standardized or clear cut. It gives quite a lot of room for divergence between different prescribers, and I feel like there's potential for standardizing orders such as this. And finally, further research. I think that's the big one. I think there's a lot more research that can be done. There's so much opportunity to investigate in other surgical areas, other general surgeries, the same general surgeries that I looked at, just in more depth and volume. Orthopedic surgery is a whole other animal, and I think would be a good one to dive into as well. It's a big area, lots of room for research. We could dive into patient utilization. For example, follow-up phone calls would be a great method for collecting data to see just how much opioid patients are using after they have left us in the hospital. And that could be something that we could utilize learners for. I know that the opioid stewardship team is bringing in pharmacy students, that we could maybe utilize them in this vein. And finally, involvement and discussion with other primary stakeholders. I've already talked about how we wanted to involve the surgeons, and I think moving forward, it would be really important to include both nursing and surgeons, those frontline prescribers and administrators, to see what they think and what they have to offer in terms of collaboration. So in conclusion, patients at the SHA Regina seem to receive relatively low amounts of opioids in hospital in the surgical groups that I mentioned. Conversely, the majority of patients still ended up receiving opioid discharge prescriptions, which is an interesting finding. I think there's some opportunity here for standardized inpatient and perhaps discharge opioid ordering and the optimization of non-opioid analgesia that can help us to become more effective opioid stewards, in an interdisciplinary and patient-centered manner. So just to quickly acknowledge my committee that helped me through the past year. Zach Dumont, who I think is on here on the presentation as an audience member. Jackie Myers, who you all know. Bill Samchuk and Sam Tree. And then Ali Bell, one of the statisticians in Regina, and the HIMSS workers. I couldn't have done it without all of them. So that concludes my presentation. If anybody has any questions, I would be happy to answer them. I know that was a lot of information very fast, so I'm happy to explain things a little bit more if needed.
Yeah, thanks for that presentation, Brandon. That was great. If anyone has any questions, you can either enter them in the chat. I haven't received any so far. Or feel free to unmute your mic and go ahead and ask away. We can wait a moment. If not, I have some questions. So,
terrific.
Maybe I'll start then. We'll give people a chance to think. So one of the things that I saw, Brandon, was you mentioned that there were relatively low amounts of opioids used while they were inpatients. I'm just wondering if you have any insights into that. Is that because of potentially the type of surgery, or because of other pain control using, NSAIDs or other things like that? Why do you think that might be the case?
I think that's a really good question. And there's a couple things that can perhaps be inferred or maybe thought about in terms of future hypothesis for further research. It might be the case that that the patients themselves simply didn't have that much pain and didn't need that much pain control. We see that that only 3/4 of the patient population got Tylenol too, and only a fifth of them received NSAIDs. So it may be the case that they simply didn't need too much pain control in these types of surgeries, which then leads us to say, so why are they being prescribed such high doses if they don't need it? Conversely, the other potential answer is that maybe these patients do need pain control, but nursing staff, for example, they're already being opioid stewards, kind of, as it were, right? It might be the case that nurses are aware of proper and appropriate opioid administration to at least some degree, and that's contributing to these low rates of utilization. So that's a conversation that needs to be had then with those other stakeholders, with the physicians and with the nurses, and kind of tease that information out, and then also do some follow up with patients to see if they were even experiencing too much pain in these types of surgeries.
Yeah, that's great. And it's too bad that you didn't have the opportunity to have sort of a round table with some of the surgeons and other members of the team. That I think could have been useful for just further information. But yeah, hey, that's future work, I guess, right? So I think in relation to that too, one of the things when you showed that screenshot of the PPO, I found that interesting because one of the first things when in the world of antimicrobial stewardship, one of the first things they talk about when you're designing pre-printed orders or pop-ups for like CPOE and stuff like that is when you're going to suggest a therapy, suggest the most highly recommended one first. So, even on that list, it looks like there'd be an opportunity to just put the, Tylenol, acetaminophen first on that list. And then just because of human psychology, as we're going through that, we tend to check off the top ones first and ignore the bottom ones once we've met what we perceive to be the need. So even doing something as simple as putting opioids lower on that list could be a potential area for improving some of that ordering. So I just wonder if there are other parts of that PPO that you thought would have room. I know you mentioned some of that stuff about that first part, but if there are other parts of that PPO that you thought might have room for improvement as well.
Yeah, I think that's a really good point. And in terms of like opportunities for even just spatially like moving things around, that was actually something that I saw in the literature, is that, for example, on an order set, having the non-opioid pain control as one section, and then on the back side of the order set you have the opioids, or just underneath it. And specifying you should only use one of these opioids, or specifying dosage recommendations, because those aren't necessarily done in currently existing PPOs. I think, there's a lot of opportunity there. In terms of that PPO specifically, I'm not too sure, but those lists can definitely be optimized, I think.
Great, thanks. Any other questions for Brandon? Well, if you do, his email's right there. You can certainly contact us as well, and we can pass it along to Brandon. So, Brandon, I just want to thank you. That was a great presentation, and yet another great pharmacy resident project that's been done, and with some hopeful future opportunities to continue to engage with that. So, thanks again. And thanks everyone for joining us.